you will have to evaluate for, something that you will have to manage to some extent. It's very common. It's actually increasing in incidence. So this is an important topic. You don't have to memorize everything now, at least before the test, and then obviously seek out patients in your phase 2 where you can start to practice putting these concepts into practice. All right, so asthma. We're going to go over the pathology of it. I updated this lecture about a year ago, went through it completely. There's a lot of updated guidance on asthma. When you get to pediatrics, this is a huge pediatric topic as well. So the key point takeaway here today is that asthma is a constantly evolving disease. And when you get out into practice, the things I teach you today may not necessarily be what you see. There's tons of new medications coming out. There's a lot of genetic things that are coming out where we're learning how to manage things differently. There's some environmental things that are happening. So you always just want to make sure that you're keeping up on your, remember we said this is what the studies say today. This is one of those topics you're going to want to make sure that you're keeping up with evidence-based medicine. All right, we'll talk about managing, and then we'll talk about exacerbations. We'll just touch on exacerbations in this course. When you get to EMED, they'll go into a lot more detail on how to manage these in an actual emergency room. All right, so here are some key points. When you think about asthma, when you think about the pathophysiology, the how, and then you understand the why, or the why and then you understand the how. So what's happening inside the body that we understand, because this will tie very importantly into how the patients will present, what that exam will look like, what symptoms they'll have. And then the pathophysiology will tie into, well, what do we need to do about it to manage it? So thinking about, once you identify that it's asthma, how do we need to address this patient in order to reverse this airway obstruction? And then all of, I always call this the so what, right? Getting people to quit smoking. Why is that important, right? Making sure that we have patients under good management where we're treating them for asthma, because this can cause permanent airway problems in these patients. The more time they spend in this obstructive edematous phase, the more likelihood that we have airway remodeling, and then we have permanent, not recurring disease and symptoms. So again, we said very common. This is typically a young person's disease. So you'll see this much more in your pediatric age ranges. There are recruits that don't tell you that they had asthma as children. You will find this out early in their military career, that they forgot to tell people that they were treated for asthma as kids. This usually happens in places like the field, or this happens on aircraft, or this happens in places where you don't have access to emergency services. So identifying this early, making sure it's under control. These are the patients that will, especially in field settings, be really, really, really frustrating, especially when they don't bring their meds with them. So chronic disease in kids, again, pediatrics, next semester you will learn a lot more about asthma in terms of that pediatric population. Again, it's increasing in prevalence and increasing in hospitalizations. Here are the risk factors for asthma. So there is some, again, we start at the bottom, there's some genetic influence. This atopy, this ties into the fact that a lot of asthma specialists, so when you refer someone for asthma, when you get to the point where you need a specialist to help manage it, in a lot of cases, that'll be an allergist. You would assume it'd be a pulmonologist, but at least when I did my training, referring someone for asthma, when we refer them to the allergist, because so many of these are correlated with atopy. One of the first things she did when she would get her patients referred would be to order a panel of labs, including this IgE. There's also ethnic disparities, antibiotics, infections, And then obviously allergies and tobacco. So risk factors for developing asthma. This is what happens. This is FYI. It's a lot of words. I don't want you to memorize it. Again, where we're getting to with all of this is lots of edema and lots of obstruction of airflow. If you look at this picture, it becomes edematous. Mucus production goes up. Traps air within those alveoli. You cannot ventilate air. Remember, we talked about asthma being, someone's in an exacerbation, we do not want to send them for PFTs. This ties into that. So when you have someone force expiration, it actually causes this hypersensitivity to get worse. So it clamps down a little bit tighter when you have them try to force expiration. And then this recurrent cycle, this is what leads to that airway remodeling. This is what we're trying to prevent by making sure that we have good routine care for asthmatics. A, we have to know it exists, and B, we have to get them educated. Go ahead.
I was just curious, so if they did go through the airway remodeling, would they present like on initial exam similar to like a COPD patient?
Yep. Exactly. So the question was, if a patient has long-standing asthma and they have developed this remodeling, this edema, that's now become permanent, we've got the damaged tissue, we've got collagen deposit, would they present like a chronic obstructive COPD patient? And that's correct. They'll have similar PFTs. Actually, it'll be less reversible, right? So we talked about PFTs briefly and how obstructive, right, the FEV1, FVC goes down. But with asthma, you give them the bronchodilator and they can reverse more than 12%, right? So when patients are long-standing, then this becomes permanent and they don't respond as well to the bronchodilators. So the bronchodilators start not working as well. When it's early on, they work really well, get them back down to a normal lumen size, and then their airflow restores. Again, we're doing the same thing, right? Something triggers. I highlighted this on this slide. There are several disease processes in medicine where identifying a trigger is critical to effectively managing that disease. This is one of them. So a lot of work, at least when I did my month with the allergist and we saw asthma patients every day, a lot of the work she did with these patients was trying to figure out what their trigger was. Was it dust mites? Was it the cat? Was it something in their yard? What was it? What was triggering that? In some cases, it's a viral infection, right? Not really much we can do about that. But that's very important because when we find out the trigger, it becomes a very powerful tool for the patient or their parents to try to avoid this cycle. Another disease process in medicine where we see this very commonly is migraines. What's your trigger? Sometimes you don't know, but if you can figure it out, if it's a food, if it's I had a patient that got sunburn. Every time she got sunburn, she got a migraine. If you can identify that, it's very powerful in terms of avoiding that. So precipitants, triggers, some of those we've already discussed. There's the allergens, dust mites, cats. Oh my gosh, cats. God bless them. But I can't tell you how many patients we would see where, I mean, their studies would be just through the roof in terms of kids being very allergic to cats. And we would just have to have these, almost arguments with these families. Well, they don't sleep in the room or they don't. But that is why their children were so poorly controlled. Every patient that saw Dr. Brown got dust mite pillow covers. They all got an IgE. So we're looking for things to identify these triggers. Does anybody in the house smoke? What do you do for a living? How often do you get, do your symptoms correlate with getting sick? Usually that's a yes, but are we not sure? And then we've got our exercise-induced things. So regardless of the trigger, this is what's happening. The airway, right, we're down in the bronchioles. Remember, that's where we have smooth muscle. That's where the changes in diameter are occurring. So if we're in the bronchioles and we do an exam on someone, do we remember anatomically what our sound, our auscultation sound that goes with that? So we had stridor, we had bronchi, wheezing, and that's classic, right? But not all that wheezes is asthma. Sometimes it's RSV. All right. This is another trigger. This is probably not going to be a very clinically high yield, but if you look at this, about 4 to 10%, at least based on some study, about 4 to 10% of your adult asthmatic patients are triggered by aspirin. When you do your physical assessment of patients, we'll talk about things like looking for polyps. We're talking about doing a medication reconciliation. Because if you have a poorly controlled patient and you can identify, you can be that clinician, and this is what PAs are classic for. Not, really doing the work step by step every single time, making sure you're going through every step. And you can catch something like that and identify that, and the patient stops having asthma exacerbations because you were able to identify that. That's like a gold star. You're doing such good work, if you can do that. So it's not going to be a high yield thing. Just keep that in mind. All right, so what are patients going to present like? So we talked about this. So early on, it's going to be episodic. That is classic for asthma. So they are exposed to a trigger. Their airway is hypersensitive, and so they bronchoconstrict. They tighten up. So the smooth muscle responds and tightens. They're going to increase their mucus production. So again, we talked about that wheezing. We talked about coughing. These symptoms, we're going to talk about when we're assessing control, and we're going to be asking about nighttime symptoms. So nighttime awakenings because of asthma is frequent enough that we actually decided to use it in one of our little check boxes that we use in the clinic. These are other things you want to consider. When they were diagnosed, did they have PFTs, especially in the military, right? This is something that's important to document. Major Klein will talk about treating for asthma minus PFT confirmation. So it does happen. If someone's already had PFTs, but in the military, if you're suspecting it, you're going to want to go ahead and order those documented. Right, so do you notice your symptoms get worse in the fall? Do you notice your symptoms get worse during allergy season? So trying to figure out triggers. The daytime, nighttime frequency. How often you use your rescue inhaler. These two here, you should ask every single time because this is how we assess control. And we'll talk about that later. When you see things like this, these lists, in the back of your mind, when we talk about building templates for patients in the clinic, this is the kind of stuff that we're talking about. This will make your life a lot easier, especially if you're trying to utilize your team to do good screening. When you have clinics and you're seeing something frequently, building these types of things will make your life infinitely easier. Because if you have checklists like this, then someone else can be in the room asking those questions. You don't have to train them to remember all these things. Just keep that stuff in mind for putting in when you're out there and it's your clinic and you're wanting to be more efficient. All right, so again, we talked about doing the physical exam. Atopy, so allergic tendency to develop an allergic response, the mast cell degranulation, all the things that happen when your body mounts an allergic response to a trigger. So that's stuff like runny noses, remember we talked about looking up people's noses, getting in there, looking for eczema. That's another associated atopic medical condition. Look in their nose. Samter's triad, we talked about that one. So asking about all three of these things, looking for that on the MedRec, making sure they're not on something that could be a possible trigger. Vital signs are vital. Remember we talked about signs of acute respiratory distress. Obviously, you listen, do you hear any wheezing? Usually, you cannot hear wheezing, but you could if someone's in a severe attack. But typically, if someone comes in and they're not in any respiratory distress and they say, I'm wheezing, a lot of times they're confusing upper airway sounds for wheezing. Because true wheezing is usually in that end expiratory phase. So when they are completely breathing out, that's when you want to zone in and listen to the base of the lungs. And right at the end is usually when you'll hear that right at the end. But when someone's in severe attacks and that airway is so clamped down, sometimes it can certainly be audible. It's a bigger instrument we're dealing with at this point. And then all the concerns we have for more significant respiratory distress. The body is not moving air and that CO2 is building up. And patients are beginning to become acidotic and they desperately want to vent off that acidic CO2. Because the longer they stay there, the longer they stay in that air trapping, right? Their body's starting to build up CO2, the tissues are becoming acidic, and when they become too acidic, then the function, biological process of the body starts to break down. You will know about it quick. You will know about it very quickly. All right. So diagnosing it, so if you suspect it, right? We talked about the clinical features. Patient comes in, they're complaining about symptoms, right? They're giving you all the buzzwords. Chest episodic, it's tight, whatever. You do an exam, you hear some wheezing. So now you're thinking asthma. This might be asthma. Even if it's just history, don't forget, patients sometimes are not in an acute asthma exacerbation at that point. Maybe they come and they say, I get these symptoms, but today I'm good. So even based off of history, you send them for PFTs. Remember, we get our FED1 FEC. This is where we're looking for obstruction. If it's less than the lower limit of normal, and the post-bronch FEV1 improves greater than 12%, then we can define that as reversible obstructive airway disease. Does that equal asthma? No. On the test, yes. But in real life, it's probably asthma. But there's always that, they'll say something like consistent with asthma, but it doesn't mean that they 100%. Another thing to note is that we talked about normal PFTs not necessarily ruling out asthma. The patient could just not be in an exacerbation that day, and their diameter is normal, so they've got no obstruction. So the PFTs could be normal, but man, they've got great symptoms. Their symptoms, they just sound like they have asthma. I saw nasal polyps. They have eczema all over their body, right? Their parents had it. They smoke. So everything is pointing to asthma. Then we talked about doing this methacholine exercise challenge. If that's negative, they probably don't have asthma. You gotta look somewhere else. But if that's positive, in my case, I would probably just start treating them for asthma. If they failed it, then I would probably refer them, because maybe it could be something else. We talked about that newer study. Again, we're not going to test you on it, but you may see it once you get out to practice. Again, it just goes a little bit further than just testing the mechanics of it, and it actually goes down into the next phase of oxygenation, which is getting it to and from the tissues. Chest x-ray, add that. Remember chest x-ray, the dollar signs. Don't be afraid to order it. Don't be crazy with it. But this is a low threat, usually pretty accessible test that'll give you a ton of information. And normal studies are just as important as positive studies in terms of what you don't see. All right, peak flows, again, not diagnostic. We talked about those, using those in clinic or giving these to the patient so that they can assess how they respond. We'll talk about that in touch when we talk about asthma action plans. Other things that can present like asthma that you should have in your differential, you should be considering. So COPD emphysema, so you got a 22-year-old patient that's never smoked, you could probably put that one way down there. Heart failure, same patient, you could probably put that one. PE, it's not going to be episodic. So just when you start to move into the clinical practice, when you get into your clinical, start to go through differentials as you learn more about these diseases and try to think out, well, what would this one look like that's different than asthma? How would that present differently than asthma? This patient had surgery. This patient has a swollen lower extremity. We haven't talked about PE yet, so I won't get into too much detail, but we will. Check for medications. This one down here, that's called vocal cord dysfunction. We're not going to really talk about that one. A lot of patients, did Hansen talk about VCD in ENT? A little bit, okay. Yeah, so this is commonly misdiagnosed as asthma. This is the patient that thinks they have asthma, came in, has normal PFTs. I sent them for the methacholine challenge. It was negative. Now I can go back to them and say, it's not asthma. It's probably this. And try to convince them to be compliant with what we need to do to manage that. All right, here's an example PFT, the red, right? So remember, the volume, so from here to here, right, blue's normal. I'll reorient you, blue's normal. So the volume of air, when they inhale and blow out, the volume of air is about the same. So they've got no restrictive airway disease. Their lungs can still hold the air. They just have a hard time pushing it out. They get this little sad, and then this difference from this dot down to here, that's that drop in that FEV1. And in this case, it surpasses, right, that lower limit of normal. Otherwise, we call it normal and not obstructive. I mean, this is a stupid question, but if you had to guess, it's good test taking skills, right? So this is a patient, 26-year-old. So where do we go first when we're evaluating these? FVC or FEV, whichever one you want to start with. So we'll start with the FEV1 FVC. So right here, the percentage. So this is what the patient blew, and this was the lower limit of normal. So is it decreased or normal? Right. So we know we're not going to have normal, and we know we're not going to have only restrictive. So it's between obstructive and mixed. And we're going to come back up here. FVC, hers was 4.84, lower limit of normal was 3.74. So what is the primary pattern of this PFT?
Obstructive.
Obstructive. Did everybody say obstructive? I know you did. Huh? Yep. Yeah, because there's a post, right? So we know it's obstructive at least. All right, so now we look at the FEV1. We come out here, we look at the percent change after the bronchodilator, and is it reversible? Yes, because it's above 12. Good. All right. So here's the problem with asthma. It doesn't matter how well controlled you are, you can still have a fatal asthma attack. You can be walking along, 18 years old, you know, you have asthma, and you could fall into a pit of cats, right? You could get stationed at a place where all of a sudden you are living in an area where you are severely allergic to something in that environment. So at any point in time, this is why education is so important. This is why identifying asthma is so important. It's like people that have anaphylactic reactions. You almost want to tell them forever and ever and ever, we're just going to stick this EpiPen attached to your body forever. It's not the case, but for patients who have ever had asthma, I always tell them, it's not going to be the dumbest thing if you have an albuterol inhaler somewhere, because you never know when you're going to reintroduce yourself to that trigger that you didn't even know existed. So that's a key point I want you guys to keep in mind with asthma. This is why it's important. This is why we have all these societies that talk about it and the importance of it, especially in the pediatric population. We don't like kids dying. We don't like it. We like to do education. It can happen slow, you have time, or it can happen fast. So plan for it happening fast. Don't bet on this. Now, if you're screwed and you're waiting to move somebody, right, you can pray for the slow onset, but just pretend like it's going to happen fast. Move them fast. And then things that make sense, right? It's more common in patients who overall have bad control, poor perception of their symptoms. They've declared themselves as having a really hypersensitive airway in the past, one that can be so hypersensitive that it closes off. Oh, sorry. If they're known to have that aspirin NSAID sensitivity, obviously if they smoke, and if their forced expiratory volume at 1 second at the baseline is low. And this all makes sense. Not that you shouldn't educate everyone with asthma on the risk of severe asthma attack, but these ones, you should really drive it home to them. You are at a much, much higher risk if you fall into any of these categories. All right, we'll keep going. All right, management of asthma. So one of the main reasons I rewrote this lecture a year ago is because there's several different guidelines that we use to manage asthma. And so as primary care clinicians, the question is, which one do we use? How do I build my protocols in my clinic? Well, first of all, what's on the pants, right? What are they going to ask me on the pants? But really, this is one of the bigger challenges in medicine, is that you will have new guidelines, you will have updated guidelines, you will have things come out, and then everybody will get together, they'll read the new studies, and then they'll say, okay, so how does this apply to me? I want to make sure as a clinician I'm meeting standard of care. I want to make sure that I'm up to date on what I am doing for my patients. But now there's these new guidelines that come out. So how do we implement this? How do I make sure that I'm taking care of my patients? So being aware of it, the first thing that I usually do is you want to get yourself included in some sort of, you guys are students right now. You're immersed in all of this reading and all of this literature, and you're studying medicine right now. Then you're going to go out and do clinicals, same thing. Then you're going to go out and practice. And you will be far away from all of this. And you will have learned to do things, and you will just start doing them. So you have to find a way to reconnect yourself with medical education. Whether that's a journal, whether that's something that you do within the clinic. If you are assigned to a place where they do have GME, coordinate yourself with that. Go to these things. At least, like I said, get a good journal that you can be getting all this information from. Next thing I usually do if I see something come out that looks new is I talk to a specialist. I go and I say, hey, cardiology, what do you think about these? And you ask them, and they'll usually give you some sort of answer to help rewrite to figure that out. You have chief medical officers at your MTS. They are supposed to also be ensuring that the standard of care within your organization is high. So keep up with this stuff, work it into your, we have, for licensure, we have CMEs, we have continuing medical education, we have requirements that we have to meet in order to be privileged and credentialed. This is what they're trying to get at. So they're wanting to make sure that a clinician that's been out of school for 10 years isn't, you know, and I've worked with clinicians like that, where they're doing stuff and I'm like, wow. I don't know if you guys ever heard of gentian violet. We used to give it to kids. It's like this purple dye stuff that you put in their mouths. Right, no one's ever heard, has somebody heard of it? You say, yeah. So I don't think we've been doing that for decades. And I had a pediatrician, and every so often I see a kid leaving his office with a dark purple mouth, so. What in the God's name are you doing? And he was not a good clinician, as it turns out. He was a pediatrician, but he never examined his patients. He never physically touched them. It was the most bizarre thing. All right. So this is a list of all the different guidelines that are out there for asthma. So the big ones I want to focus you in on is this global initiative for asthma. I think pharmacology likes this one because the pharmaceutical companies wrote it. This is a global, I know, Major Hart and I, we love to take digs at each other. So this is a global one. The other one is the national one. So expert panel reports, 3, 4. I will reassure you, hopefully, that they pretty much say the same thing. There was one place where there's a little bit of a difference, but I'll reassure you they pretty much say the same thing. And the second piece I'll reassure you on is anything that involves test questions. I'll make sure we're tracking. But this is important to know that we literally last year, Major Klein and I had to go and meet with pulmonologists and of the USHIS, the military medical school, and sit down with them and come up with how we should teach this in PA school. And literally they had just come up with a few lectures to talk to their own students about. So the one that I will test you on is going to be this EPR. And I'll don't worry, I'm not going to make you memorize a bunch of charts, I promise. Alright, that was a lot. So this is another thing, I like to show you what these algorithms look like. Little things that when you're out in clinic and you're learning stuff and you're like, oh, this patient has asthma, and you like panic because you forget all my slides. You forget Major Klein slides. There are good resources online that are good to have, that are good to review. Little algorithms that are great. They're out there. Use them. They're there. So this is just some of the updates. I just stuck this in here. So again, this is the stuff that you as clinicians out of med school, away from educational platforms, these are the kind of things that I want you still interacting with. Looking up, reading. Especially when you're in charge of other clinicians. Oh boy, you will have to make sure that they're doing the same thing. They're not giving gentian violet to their patients. So these are big updates from EPR 3 to EPR 4. One of the big things that we've moved to is this inhaled corticosteroid. In the old days, that was an add-on. Now we're going to this much quicker. Again, we teach you in the first 2 years of school here to be scared of steroids, and then we're like, but they're not bad. But they're good in certain settings. So we'll see that we've gone a little bit closer to using steroids earlier and more consistently. And then we've got some of these new fancier meds, immunotherapy, right? Allergy shots. You'll see that as part of asthma treatment, especially if someone has severe allergies. The problem with allergy shots is they set the profile for where you're at, and then you PCS in the middle of your allergy shots. It's a huge frustration, because then we have to redo your panel. It's like, oh, this one's for Texas, now you're in Georgia. So it's very, very useful. I've seen it be very, very helpful. When patients are very poorly controlled, I think it's 100% worth pursuing, especially if there is a clear allergen that cannot be avoided. Just keep in mind that when you're active duty and you move a lot, it's a little frustrating, so you may have to restart a couple times. Very, very time intensive. Has anyone ever gotten an allergy shot? I guess that's part of microbiology, but yeah. So very time intensive up front. You're going in a lot for those shots. Did you find them effective? Good, yeah. Good, it works, success. You wanted to die though? No? Alright. And remember there's that testing, right? So this testing we talked about, we touched on. Not going to go into full detail about that. You may see it though when you get out, depending on where you're at. As an adjunct to those PFTs. And then the bronchial thermoplasty, that is the, the lung transplant. It's kind of the highest level. We talk about pneumothoraxes, there's surgery. This is usually reserved for the worst cases. Because when you do surgery, in general, your outcomes are 50-50. So the risk has to be worth the benefit. All right, so now we're going to talk about asthma severity. So we have all these different, when you just start doing your ICD-9 codes, you're going to have asthma, and then there's going to be about 16,000 different qualifiers for asthma. Mild, intermittent, blah, 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 all these different qualifiers. So when we talk asthma, we want to make sure that we're communicating severity of asthma. Because severity of asthma is what dictates, in general, what we're going to prescribe for the patient. So severity and control are kind of two different things that overlap. So their current impairment, so that's how frequent their symptoms are. This is you interviewing a patient in front of you. How often do you wake up at night? How often do you use symptoms? How often do you use your rescue inhaler? If that's part of, if you've already been given one, right? Usually the number of symptoms and the number of SABA use should correlate, right? Because we tell them when you get symptoms, use your inhaler, but sometimes they don't. Sometimes they forget it. So we ask them separately. And then how often, what's the interference with your normal activity? If I feel a little chest tightness, but it doesn't really affect anything, it doesn't last long enough or affect me enough to use my SABA, again, you're going to get less points for those overall. So we're getting a couple of different things, and we're getting an overall score. We don't want to base things on one individual question. And then future risk. And remember, if one's in a category 1 and one's in a category 3, we round up for these. So you want to assign the severity category for the most severe of all of those questions. All right. So this is the NAEPP. This is a patient who just came back from their PFTs, and you say you have asthma. Yep, we got your PFTs back, your FEV1 FVC ratio is low, and you had an 18% response to bronchodilator. So congratulations, you have asthma. So the first thing we want to do is figure out how severe it is. Because if you look all the way down to the bottom of these, depending on what the severity is, that's going to determine where you start your treatment at. Keep in mind, in this course, we are staying to the right. Right, staying to the right. Does anyone ever see Goonies? Stay to the right. Right, stay to the right. And I do this all the time when I'm writing test questions. As I start drifting over in here, that's not what this is major Klein plan. We're staying over 12. You stay to the right. You ask the questions. And then the next slide, I think I show you which questions we're gonna focus on. I'm not gonna give you all of this information. We're gonna simplify it and stick to just some basic questions in terms of testing your ability in this course. All right. So now we have a patient who we're following up. So now we want to see how well controlled they are. Again, this is where we're not talking about where to start. We're talking about where to go, up or down. Okay, staying on the right, all the way over here. This is the 12th, so you're going to ask them how often you get symptoms, how often do you wake up at night, and then again, all these questions will be part of the assessment. And then you determine which category they're in. If it's well controlled, this one says maintain current plan. Good. But it goes on to say, if the symptoms have been well controlled for more than 3 months, you can consider stepping them down. So it gives you an option to discontinue medications, which I love. And so forth, not well controlled. All right. So they're having symptoms more than twice a week. They're waking up at night. They're using their inhaler more than twice a week. We consider that not great. So we may want to step them up, and I'll show you what that looks like as well. I know you guys have already touched on this in Pulm, so. This is another tool. This was something that was in our clinic. So again, you're trying to not just make clinical decisions, but at some point you're going to be managing patient care. You're going to be the OIC of a clinic. So when you're developing these things, it'll make your life a lot easier, and you'll give more value to your medics, to your LVNs, to your RNs, to everyone else in the clinic, including your front desk, that when you have patients come in, you hand them out this information. When you go in the room, you already know. So you can kind of be that much farther ahead of the visit, instead of walking in and, you know, here's the vitals, ma'am. And you're like, any history? Do they have any meds? And yeah, so. Fortunately, unfortunately, however you want to look at it, you will, in a lot of cases, have to drive that to make sure that your team is fully utilized. All right. Here's the goals. So what are we trying to do? We want to reduce impairment. So we talked about symptoms. We talked about nighttime symptoms, right? Don't want people waking up at night. We want to keep them healthy. We want them to have normal daily activities. We want to have them maintain normal lung function as frequently as possible. The more time they spend in abnormal function, inflamed, full of mucus, poor ventilation, the more time they spend like that, the more likely that remodeling will end up being permanent. And then we want to reduce the risk. Keep them out of the ER. Keep them out of the ER. And then we talked about stepping down, remember? So that's another thing that we always want to keep in mind. There are side effects of treating them as well. The goal of managing patients isn't to get them on the most meds possible. It's to have them function as normally as possible while reducing any risk of long-term disability or death, obviously. All right, so this stuff is laid out on those charts in terms of follow-up. So if we go back to this one here, you go down, this also talks about follow-up. It depends. So there's a range there. I freaking hate ranges. Follow-up in 2 to 6 weeks. Well, which one, right? How do you decide how soon you want to follow up?
Severity, initial ones.
Severity. Yep, how many changes you've made, how compliant they are. Hunger factor, how insecure you're feeling. I literally would have people that I saw in the morning come back and see me at the end of the day sometimes. Kids especially. Yep. So just clinical judgment is based off of, is this someone who totally reliable, has very minor symptoms. I just gave them an albuterol. I'm not even sure if they have asthma, but their PFTs were very reliable, good access to care, very reliable, all that stuff. Good social home care stuff. You can let that go a little bit longer. You don't want to be that crazy person that's, I had a provider I worked with, and there was constantly patients walking in the front desk. I was like, Mark, stop. Because he'd just be like, come back and see me, come back and see me. And they would come back and see him. So you want to be very specific about it. Just remember, whatever you decide, you give them return, you disposition them, follow up in 2 weeks, but you give them red flags and early return precautions too. So every time you write a plan, it should be follow up in 6 weeks, or go to the ER if you experience any life-threatening, That should be part of your, every time you write a note. This is what I think is going to happen to you when you go home. Right? Yeah. Right. Right. Let's see here. At every visit, educate. Your success as managing asthma will be in creating knowledgeable patients or patients' parents outside of the clinic that understand what my kids' triggers are or what my triggers are. Now, there's studies on diabetes that the simple act of checking your blood sugar by itself independently improves your control. So getting them, that's why I like the peak flows. I like them to be able to check it. I like them to see what happens when they use their albuterol. It puts something in their brain that, hey, this works. Or more importantly, hey, every time I go outside and I haven't taken my allergy meds, I start to have trouble breathing. Like, I love that. When people can put that stuff together, they can self-manage. It prevents them from getting those exacerbations, having to come to the ER. Asthma action plans, right? You may have to fill these out for schools. This is where we use our peak flow. You look in there, basically what you're telling them is, just what we just taught you. If they have symptoms, which symptoms to ask about, when to give the albuterol, and then when to seek emergency care. Make sure we're vaccinating. Again, there's association with illnesses. Making sure we're getting them to quit smoking. Treating their allergies, talking about irritant exposures. Making sure they know how to use their medications. Education, education, education. All right, let's take a 10. Where are we at? We've got 9 more slides. Take a break. We're going to talk about asthma. Finish these last 10 slides and go to lunch. All right. So stepwise approach. I don't know if this is something you've seen before or not seen before. I'm pretty sure you saw that one in Pulm. All right, that's with Gina. My baby sister's name is Gina, and every time I say her name now, I'm like, ugh. So you'll see why. All right, so stepwise for management. So this is the NAEPP, and I'll give you a good news right now. Most of my test questions are going to have the charts on them, right? So most of my test questions are going to describe a patient. I'm not going to expect you to memorize. Oh God, if it's more than 2 days out of the week, or they're not, I'm not going to expect you to memorize all those little charts. For the ones where I want you to determine what level of severity or what level of control, I'll give you the information. Because at the bottom of those, then we're going to be able to connect the steps. So this is, I'll reorient you. The bottom of the control and severity charts discuss steps. And this chart here is one that it will talk about. There's going to be 3 boxes on here that I would like you to remember, but we'll get to that. If you look over to the right, this just goes over some of the drugs, refreshes you from Pharm. You've got our SABA, that's our short acting, that's that beta 2 agonist. We know those beta 2 receptors in the tissue. So we're agonizing them, we're stimulating them, leads to bronchodilation. Inhaled corticosteroids, right? Decreases all that edema. And we talk about oral or systemic corticosteroids, our Medrols, our prednisone. That will be also used in management, one of the drugs that we'll go to. Our LABAs and our LAMAs, we'll talk a little bit more about those when we get into COPD, so our long-acting. When we're talking about pure asthma, not that chronic stuff that's turned into remodeling, usually we're going to use these short-acting over the long-acting. But there is a role later on in stepwise therapy. So this LABA, we used to have this black box warning. In fact, we still do, about using a long-acting beta agonist by itself with asthma. So I looked it up, I read it in detail. I don't know if you can comment on that, but I guess when we used it we use it all the time by itself when we do COPD. But in asthma, there were some studies, I'm trying not to get into my conspiracy theories, but it said that there were worse outcomes for pediatric age kids when they were just on this long-acting beta agonist by itself. So even though we'll see the formoterols and the salmeterols by themselves, when we talk about using it in asthma, it's more than likely going to be combined with something else. All right. So we'll start with the preferred. So orient you, and I'll have these all circled on the review too. These 3 boxes, the preferred step 1, 2, and 3s, this is more than likely the realm that we as primary care clinicians are going to be involved with. Because after step 3 treatment, usually it tells you to start thinking about referring. Same thing with high blood pressure, right? Once we've got them on a few medications and they're not responding and we know they're taking it, then we start thinking about maybe we need to call a cardiologist. So after step 3, maybe we need to start thinking about using a specialist, an allergist, immunologist, a pulmonologist. Because when we start getting into some of these special meds down here, sometimes you actually need the specialist to put in that first prescription. And you only have 20 minutes with a patient, so they have like an hour. So don't use it all the time. Don't have someone come in with 1 high blood pressure and send them to cardiology, or they leave once. But at some point, when you feel like you have got them on sufficient primary care management and you're still not reaching your goals, then we'll refer them. So we'll stick with the step 1, step 2, step 3, and we'll stick with preferred. All right. This is Gina. So what I will tell you is, they're very similar. It's just how they recommend the meds. So this is very driven by, it's very med-centric to me. So what you will see, if you go back to the NEEPP, step 1 is as needed short-acting beta agonist. So if you look at Gina, that is down here in the other. If you go back to NEEPP, right around here, around step 3, we introduce this inhaled corticosteroid, that's Symbicort. I don't have a problem with Symbicort. There's a lot of great studies on Symbicort. It improves outcomes, it decreases morbidity and mortality, so it's not a bad drug. So you take that inhaled corticosteroid and put it with a long-acting beta agonist and have them take it daily and as needed, achieves good outcomes. You look at GINA, they recommend that right out of the gate, as needed. So that's the big difference between GINA and NAEPP, is that GINA introduces that formoterol a lot earlier in the algorithm as the preferred. It doesn't mean that what NAEPP, right, is not included in this. They just get a little more aggressive at step 1. More meds, which, you know, depending on who you ask, you're the patient trying to pick them all up and keep track of them. But this is really the big difference, is that they introduce this formoterol in step 1. Don't be too overwhelmed by it. Again, there is a difference, but by the time we get to step 3, they're saying the same thing. It's just in these lower steps, when patients are intermittent or they're very mild, NAEPP will keep them on, try to just have them on that PRN SABA as needed. At step 2, they'll add a daily low-dose inhaled corticosteroid in addition to that PRN SABA. And again, we're going back. I'm going to be giving you the charts so that I will give you a patient. I will give you the symptoms. Again, when you're in the clinic and you're trying to manage stuff, make sure you build your clinic, your protocols, so that you are getting the necessary information in an efficient manner, that you're asking those questions, that you have someone that can ask them those questions, so that when you go and see them, then your job is to make these decisions at the end of that visit. So get all that information that you have. When they talk about support staff operating at the highest level of their license, this is what they're talking about. Train people to do these things so that when you come in, you fulfill your role as the clinical decision maker, and you're not wasting your time collecting all this patient information. You certainly want to verify it, you certainly want to validate it, you certainly want to make sure that you've got correct information. But what you're trying to get to is, how well are they controlled? How severe is it? What do we need to do? Clinical decision making. Because then after that, you just follow the charts. Within reason. All right, make sure you check allergies, make sure you ask about previous responses to treatment. All right, so that's our GINA. Again, that one's an FYI. Once we get to step 3, they're pretty much saying the same thing. Again, they just love Symbicort. And I won't tell you who did the studies for this. But when we get to COPD, we'll talk about that one. That one's even more fun to talk about, on what their review recommendations are. All right. So this is just a little cheat sheet. So you have a question on the test that describes a patient who just got back from their PFTs and is on no medications. Look at this chart, this one on the left here, and all your job is going to be to do is to go into the vignette and figure out what symptoms they're complaining of, and whether or not they've had night. Those are the 2 vignette questions I'm going to want you to orient yourself to in order to get to that. I'm not going to ask you how often they use their SABA, because you will not have prescribed them one yet. So then what you'll do is you'll determine, based off their symptoms, whether they're intermittent, mild, moderate, or severe persistent. And then you'll come down here. This will be step 1, this will be step 2, this will be step 3. And I'll expect you to know, that's it, for the new diagnosis. So if I have a patient, they have asthma, and they've got very intermittent symptoms, so you see what I wrote, and you come up here and you go, oh, yep, they're in this intermittent, then the answer will be start them on a PRN SABA. So, shouldn't be too difficult. The hard part is just remembering how to orient yourself to these charts. But when you get into phase 2, this is the skill you're going to want to have. Talking to people, being approachable, not saying stupid things, not offending people. That was my list of things to work on. But really knowing how to use all of these resources. Because you're not going to remember everything from phase 1. Surprise, surprise. So now this will be a patient very clearly. They're there for their 1 month follow-up. You put them on step 1 treatment. Since you put them on step 1 treatment, right, which was a PRN SABA, now you get more information on the patient. How often have they had symptoms? How often have they been using that SABA? I think most of my questions have that as the same frequency, but you will not always have that in clinic. And then I'll probably add any history of exacerbations too. That one's important as well, especially once you're seeing them follow up. And then you'll determine whether they're well controlled, whether they're not well controlled. And all you have to do is come down here and read what it says. Remembering that if you're at step 1 and it says go up 1 step, right, that you know that that means you're adding a low dose inhaled corticosteroid. Are there other options? Of course. Gina, we've talked about all, you know, the preferred and the alternate for that. So there's always going to be, when we talk about pneumonia and we talk about antibiotic choice, there's like a billion antibiotics on there. So there's always options. Typically though, you're going to start with the preferred if you can. All right. So real quick on exacerbations, remember, doesn't matter if you're mild, moderate, or severe, any patient with asthma can fall into that pit of cats and have that severe exacerbation. Certainly smoke inhalation, right? Someone's got asthma that's well controlled and they were in a building that was filled with smoke for a certain period of time. So any patient with asthma, after they have declared themselves to have that hypersensitive airway, could potentially be exposed to that one trigger that's going to push them into a severe exacerbation. Keeping that in mind. This is a chart, right? One chart that talks about how we define mild, severe, or oh shit, right? Something to keep in mind is that the vital signs, right? So in the beginning, right, they're breathing increased rate. Then we go and we see someone at 36 and we go, oh crap. Something to keep in mind though is if their respiratory rate 6, that's not necessarily reassuring, right? Especially during asthma exacerbation. Because the body can only respond so much before fatigue. Not to mention you're retaining CO2, your body becomes acidic, so all of those normal processes are going to be affected as well. All right, so the wheezing, that's another one. So someone has pretty good wheezing, then they come in and they've got wheezing so bad, right? Yikes. You can actually sort of hear it. You put the stethoscope on there and you're like, wow, that is lots of inflammation, lots of constriction. So a lot more of that airway has turned into a musical instrument and it's louder and I can actually hear it. So if you listen to their lungs though and you don't hear a lot of wheezing, it's not necessarily a good sign. Because at some point, that airway will almost completely close off. And if you can't move air past that then it's not going to make the sound that you're going to hear. Pulse, right? Same thing kind of with the respiratory rate. They come in, the heart rate's 92, you're like, all right, you know, they're a little distressed, fairly calm, but you can hear some wheezing, and you're like, okay, this is an asthma exacerbation, boom. I'm like the clinician of the year. And I know I've identified this as an asthma exacerbation. Heart rate's over 120, 130. They're breathing at over 30 a minute. That's severe. That is something that you, again, we talked about how fast this can happen. You should be in the process of figuring out what you can do in that clinic and preparing for transport, or at least to get EMS on site, because they've got all the goodies. Again, so it's getting faster and faster and faster, and then at some point, when I see a kid crying and fighting, that's very reassuring to me. When I see a kid limp, that's scary to me. That means that they've kind of lost that strength, they've lost that energy to continue to kind of respond to whatever process is going on in the body. So the heart will actually start slowing down. Same thing with the pulse ox, that one makes sense. But remember, look at the patient, right? Are they using their accessory muscles? Are they tripoding? Are they talking, right? So get a good general impression of the patient. Get a good idea of their mental status, and then check those vital signs. Those are the three things you want to do as quickly as possible. IV O2 monitors, right? Anytime you're in an emergency situation, there's things that you want to do without even thinking about it. Things that are critical to assess the stability of the patient. Because if you can assess stability, then you have time to think, to maybe come up with some interventions, make a few phone calls, do that kind of stuff. All right, woo, ABGs, blast from the past. So, probably something every emergency room is going to get when a patient presents with an asthma exacerbation as part of a protocol if it's available. Early on, it could be normal. Air is still sufficiently moving that you're ventilating enough CO2 out of the body. As it progresses, patients tend to hyperventilate a little bit, trying to blow off that excess CO2. In some cases, that can lead to a respiratory alkalosis, where your pH is up, your CO2 is down. And then eventually, when that starts to fail, you trap more O2 in those alveoli, and you're unable to vent because of the constriction and the plugging. Eventually, that will develop into a respiratory acidosis. PCO2 in the body is increasing, driving that pH down. Not enough time. This is not one where we will likely see in COPD. We will see some compensation. This probably we will never see compensation unless someone has chronic asthma, changes, the remodeling. But usually we won't see enough time for the kidneys to, because that usually takes days for those kidneys to hold on to that bicarb. So you will see a low pH. And then when you get to EMED, we'll touch on the treatment quickly here, but when you get to EMED, we'll go into a lot more detail on how to manage these. But right off, don't forget about these. Don't assume. Remember my heart box and my lung box and my aid station, the lung box had a SABA in it. It had an inhaler in it. Everybody loves the NEBs, you need to use the NEB. I don't know. The inhalers work just fine. But give them a SABA. Repeat as needed. Again, in this case, we're talking about being in the clinic. If you've got an oral steroid, get it. This helps reduce hospitalizations. And then obviously, grab your O2. So whatever air they're actually moving, you're increasing the fraction of oxygen in that air. So you're in the same thing when we talk about vents and stuff. We want to increase the fraction of oxygen in that air, which is usually not 100%, but whatever air they are able to move, we want to help increase the oxygen in that. You don't necessarily have to send every patient with an asthma exacerbation to the emergency room. You don't have to send everyone with an asthma exacerbation out of the field. You don't have to. A lot of times they just forgot their inhaler. Yeah, you want to follow up with them like every 2 minutes, but you don't necessarily have to send them out of the field. Make sure you give a SABA. You can give them oral steroid. If they need oxygen, unless they're over 95, then you typically don't have to. Sometimes it's therapeutic though for people when they're nervous, when they're freaking out. To give them a little extra oxygen, it's not a bad thing. So if you have it, don't be afraid to use it. And then you just want to watch them. Like, have them hang out. Have them hang out in the clinic. Put them in the treatment room. You're giving them, you know, nebulizers. Repeat, you know, albuterol. Maybe a SAMA, right? Give them some ipratropium. The Duodev. Watch them for a little bit. Remember we talked about that walk of life test maybe? Walk them around, make sure they don't desat. And then quick follow-up. In the field, I do that within about 6 hours. Come back and see me. I want to see you. Sometimes I just have them hang out and do stuff for me. All right, you're not going back out there. You're going to hang out with me for the rest of the day. So this is a mild moderate, right? These are patients that they walk in, they're not positioning themselves, they can lay down. They might hear some wheezing though. You know they have asthma. They're tacky, or they're maybe borderline, maybe they're 99. Maybe they're breathing a little fast. Their stats are okay. So you can manage those in the clinic. Otherwise, what you do now, once you've determined that the patient is potentially not responding to treatment or they're progressing quickly, then you're going to want to coordinate for transportation. Again, EMED will go into more detail about this, but the keys to success are making sure that you're supplementing that oxygen. Don't forget the oxygen. You want to keep giving them that short-acting beta agonist because for whatever reason, whatever that trigger was, that is not going away. They're still being exposed to something. You have not been able to remove that from the trigger, or the trigger was so significant that that body is staying in that hyper-responsive state. And then move them, get them out of there. Get someone there that has more advanced treatment options. And then just things to consider outside of that. I don't want you to be out there, you know, be that person in the office where it's like, oh my God, who called EMS again? Right? And you're like, we know who it is. I don't want you to be that clinician, but I also don't want you to not trust your judgment. And if you send someone there, I just did it. I think I literally just did it recently. Oh, I did. And they're like, why'd you send them? That was stupid. And I was like, because there was nothing I could do for this person here. Like, there was no way that I was going to do the 4 to 6 hours of observation. I couldn't do it. So you'll deal with that. Don't worry about it. Because you're going to be potentially that person in the email that's bitching about it. And you'll understand though. You'll be like, I get it. We have all these people here and you're by yourself out there. So don't be afraid of that. All right. So have fun at lunch.